Thank you, Dr. Sirish. We'll now move on to the next paper, Ocular Metastasis in Eye Donors with Systemic Malignancy by Dr. Shivani Nayak.
A very good afternoon to one and all. I'll be presenting our research paper on ocular metastasis in eye donors with systemic malignancy. The estimated number of people living with cancer in our country is about 25 lakhs, and every year to this, another 7 lakh people are being added. And the cancer-related deaths per year is about 5 lakhs. And most of these deaths are in the age group of 30 to 69 years. 30 to 40% of donated eyes are from donors with cancer. Most of the eye bank consider donors with cancer to be contraindication, especially cancers with suspected viral etiology and hematological cancers are an absolute contraindication, whereas acceptance of corneas from donors with solid organ cancers are a relative contraindication. In our country, we have a significant amount of backlog between the number of corneas we retrieve and the number of corneas we need to treat corneal blindness. So if we can use this 30 to 40% of corneas, it will help us to overcome this shortage. Hence, our aim was to look for the presence of ocular metastasis, gross and microscopic, in donors with systemic malignancy. This was a one-year descriptive cross-sectional study where we studied 1 or 3 eyes of 52 eye donors with systemic malignancy. The inclusion criteria was all those donors dying of systemic cancer, and we excluded all those who had history of or macroscopic evidence of ocular malignancy. Standard enucleation procedure as per the eye bank protocol was followed, and no in situ excisions were done. Prior to enucleation, a detailed torchlight examination was done, and after enucleation, slit lamp evaluation was done. The donor eyeballs were preserved in 10% formalin before they were subjected to histopathological evaluation. When we saw any high index of suspicion of malignancy on HPE, these were subjected to immunohistochemistry. The total number of 1,398 eyes were collected in our eye bank during the study period, of which 1 or 3 eyes were obtained from donors with systemic malignancy, which constituted 7.36%, and 53.84% belonged to the age group of 61 to 80 years. The most common primaries in our study group was leukemias and brain tumors, which constituted 11.53%. 25 of the donors had no metastasis, whereas another 27 had metastasis to some organ or the other. And the most common sites of metastasis was abdominal in 17.3% and lung metastasis in 11.54%. Head and neck metastasis was seen in 13% of patients, and the most common primaries were brain in 2 and thyroid, lung, stomach, ovary, and testis in 1 each. On gross examination of these eyes, we found no abnormalities in 99 eyes, whereas in a patient with testicular cancer, there was abnormality in the iris and choroid. In a patient with promyelocytic leukemia, 2 eyes had abnormalities in optic nerve. We saw certain abnormal cells in retina, optic nerve, orbital tissue, and uvea, but these were confirmed to be non-malignant on immunohistochemistry. 5 eyes had presence of malignant cells, and these were in choriocapillaries in a patient with adenocarcinoma uterus, iris in a patient with astrocytoma brain, and ciliary body in a patient with testicular cancer. This is a photo showing malignant cells in ciliary body in testicular carcinoma. According to Eye Bank Association of America, 19.2% of corneal donors in 2005 and 6 were donors with cancer. In our study, they constituted 7.36%. And the most common primaries noted were hematological and CNS malignancies. And 51.92% of the donors had metastasis to some organ, most common site being lung, followed by liver and peritoneum. In the study conducted by Nelson et al., they found that 5 to 10% of the people had microscopic metastatic lesions. In our study, it constituted 4.85%, and all the malignant cells were seen in uveal tissue. These are comparison of various other studies. Hence, we conclude that the incidence of ocular metastasis in our study group is 4.85%, and the most common site is uvea. We recommend that if these eyes are used for keratoplasty, the following recommendations should be followed. Enucleation should be the procedure of choice, and on cutting the optic nerve, check for any macroscopic abnormalities. And any macroscopic abnormality is found, then these eyes should be rejected. A thorough slit lamp evaluation should be done, and donors with corneal scarring or vascular pannus should be avoided. Excision of the corneoscleral button should be done in the eye bank, and the remaining part of the eyeball should be subjected to histopathological examination. If the cornea is used for transplantation, then the corneoscleral rim must be subjected to histopathological examination. Do not use these corneas in children, vascularized leukomas, therapeutic grafts, limbus to limbus grafts, or keratolimbal grafts. These are my references. Thank you.
Thank you, Dr. Anna. We'll now call on the next presentation, a new